Thank you, Dr. Gulati, for the very nice presentation. It looks like peripheral nerve neuromodulation is going to supplant some of the more complicated methodologies that are often used for chronic pain. Although I'm not a pain physician, but I can understand what the direction that most of you pain physicians are going in this with this uh, new methodology, if I may use that. Don't go away because we have a few questions from the audience. Okay, since Dr. Lin was the first one in, Dr. Gray unfortunately is not with us, as I mentioned. Okay, there are a couple of questions for you, Dr. Lin. The first question is from Dr. Lucas Mikciak. I don't know where are you from, Lucas? Uh, he asked the question, can the lesser occipital nerve be visualized using ultrasound? So you have a minute to answer this question, Patrick.
Okay, so to locate the very tiny distal branch of cervical plexus is technically challenging. So I will suggest to locate the GAN, the greater auricular nerve first, because it runs out the retrosternocleidomastoid muscle layer and the curve around the SCM at the same plane. Then you track to higher level to see if the nerve runs in between the SCM and the semispinalis capitis, then go more medially. It's very tiny, so you can see only the bubble. But if you find the potential targets, then you can have a maybe radio frequency cannula to stimulate and by 50 hertz, because it's a pure sensory nerve. You do stimulation and you confirm your location. But if you are just going to do the block by local anesthetic, then you just insert underneath or infiltrate in between the two muscles. That would be adequate.
Thank you, Patrick. Here's a question for you, Amitabh. This question comes from Dr. Angel Gomez from Manila in the Philippines. He asked the question, can you use these stimulators, these peripheral nerve stimulators, like you can use with the user intervention? Like, for instance, use it like a PCA.
So interesting that you say that. Some of the protocols do have activation of a nerve for a extended period of time, a few hours, and then the device turns off, and then you can turn it on again. So clearly for regional anesthesia, people are using it this way, although the stimulation was constant in the studies. You can think of this similar to a spinal cord stimulator. People will turn on their device for a while for a function, and then they'll turn off their device. So TENS units are used from a goal-directed therapy. Peripheral nerve stimulators can be used the same way. We don't have the evidence to say that stimulation needs to be constant for a change and improvement long-term versus 30 minutes on, 2 hours off, 30 minutes on again. These protocols do not exist in peripheral nerve stimulation. They're all theoretical. And so we're learning as our patients are using the device. I do have some patients that will turn on the device for a while, and then we'll turn them off for a week and then turn it on again. And so really looking at this as a goal-directed therapy. Pain relief is almost secondary because TENS trials and those kind of things show the same thing. People are more functional, and then because they're more functional, their pain tends to stay the same, but the function improves. And so we don't have the studies, we don't have the clinical evidence, we have experience, and we have patients telling us how they use devices for future implementation of these protocols.
Thank you, Amit. I hope that answers your question, Uncle. Next one again for you, Patrick. It's a question from Dr. Tony. He asked the question, if you don't have a good enough equipment to define some of the smaller, like for instance, the lesser occipital nerve and the greater occipital nerve, knowing the musculofascial anatomy, is there a role for fascial plane injections where these greater occipital and the lesser occipital nerves are located? I think you need to unmute yourself, Patrick.
Okay, just as I mentioned, for lesser occipital nerve, you can just simply do shotgun approach and inject underneath SCM at a little bit higher level. It will numb everything, including the GAN supraclavicular nerve, as always. Yeah, but if you want to do radio frequency burn, then you just do dedicated search. But for GON, greater occipital nerve, because the common entrapment site will be two. One is just underneath at the curve around side of the umbilicus capitis inferior is number one entrapment site. And number two is that the nerve penetrate across the semispinalis to splenius and to trapezius aponeurosis. So you can do tap around the nerve course because you can get the Tinel sign for the entrapment. Then you just, because here, if you are not injecting too deep, it's very safe to do infiltration type of things. Yeah, but, and I see Tony also asked about the umbilicus capitis inferior approach. From my humble opinion, if you have good enough ultrasound, you can see all the anatomical structure clearly, especially the vascular and the major nerve. And more importantly, the spinal cord, which is a bit deeper, but it's very close to C2DRG. If you can see very clearly, then you can do injection or so-called infiltrates underneath the OCI muscle to numb C2. But if your image is not good enough, and I will just suggest you skip it.
Thank you. This is a question for Dr. Gulati. My sort of analysis of all this presentation is that surely peripheral nerve stimulation is a very novel, interesting new technology. And when it's being put up against more established spinal cord stimulation and other treatment modalities, it seems like it is here to stay. But given, the cost benefit, of course, there is a lack of data now, but are these equipments expensive when you look at these, especially, this 4 contact leads with the stimulator and things like that? What are your comments on this?
Sure. A very, very good question. Devices, I can't comment on the company's actual cost, but clearly the devices will cost very similar to a spinal cord stimulator system, especially for the internalized IPG ones. The external systems do not necessarily need to have a internalized battery. So in other words, they're external, so you can move their battery and plug it into a electrical socket, recharge it, and put another battery, but those technologies are cheaper. So you'll see a lot of the early devices to be lower in cost, have the external devices that are taped to the skin and those kind of things. And the internal system doesn't have any kind of lithium or anything that's inside a metal casing. So the external battery systems are less expensive, but clearly when you compare, for example, for acute pain, we talked about a lead being placed to a nerve. Clearly, local anesthetic blockade is less expensive than the device. Clearly, putting it in a TENS unit with pads with an external generator and external wires is less expensive than the internalized device. And so, depending on the region of the world, you're going to have to balance the technology and the costs versus the use. I will say this, when it comes to stimulation, we don't have to worry about necessarily losing motor function like you would in local anesthetic blockade. And so that's the beauty. And number two, and as eloquently Patrick pointed out, the fascial planes house much of these nerves before they go to the end organ or end muscle. That also allows you to place a peripheral nerve stimulator with multi-contacts in a fascial plane to activate or theoretically deactivate these nerves. So you can use the understanding of anatomy and underspecial or ultrasound, and we've done this. We'll put the leads in fascial planes to activate multiple nerves, locations of different nerves where you cannot see otherwise. So there's some clever things you can do for these very small nerves or nerves in fascial planes that you cannot see, but you can get to. TAP plane is the one we've done quite often. We've done serratus anterior plane for breast cancer. So you can use a multi-contact system in a clever way that you couldn't otherwise offer. So some of these devices can give you pain relief in patients long-term that you could not do before.
Thank you. Here's another question for you, Dr. Gulati. It's from Tirada Ploy-Petch. His or her question is that for a patient who's using peripheral nerve stimulator, do you have the affected limb involuntarily moving while turning on the machine? And how do you set up the stimulator?
Excellent question. In general, when you're trying to do pain relief, we tend to use sensory settings. So we'll be at 100 hertz, and so you're really not trying to activate a muscle. However, there definitely are protocols available for 12 hertz or 20 hertz, usually for low back pain and those locations where you can activate a muscle contracture. But in reality, our goal is not to build up muscle contractures. We were shown in multiple data points that we don't actually have muscle growth or bulk growth of a muscle because you activate it. What it ends up happening in general is that in most larger muscles or locations near a nerve, it becomes painful. And so really we're trying to avoid muscle contractures in large muscles. We can do this a couple of ways. We can use low frequency, 10 hertz, 12 hertz at a sub threshold or very small contraction where you can sense it, or we can use sensory stimulation at 100 hertz, really giving you a feeling. But know that a muscle really can only contract up to 20, 24 hertz before it gets in tetany, or it's just relaxed altogether. And so at sensory frequencies, 50 hertz to 100 hertz, you're trying not to contract a muscle.
Thank you. Okay, this is, we're running out of time, so I think I'll put this as the last question to Dr. Lin. This is a question from Dr. Fatima Zakaria. The question is, how do we differentiate between presentation of a greater auricular neuralgia and auriculotemporal neuralgia?
Okay, auriculotemporal neuralgia actually comes from V3, and GAN comes from cervical plexus. So the painful area is a bit different. Auriculotemporal nerve supply territory is more anterior, and the GAN is more posterior around the external ear. Yeah, but the simple rule of thumb is you do diagnostic block. If you suggest it's a auriculotemporal, you just inject around here, but if it's a GAN, you inject on the neck, and then inject on the neck is easier. So you just do the diagnostic block, then you locate your nerve, then you do final intervention. That's my suggestion.
Thank you. Okay, ladies and gentlemen, please join me in thanking Dr. Gulati and Dr. Lin and Dr. Greer for having taken the time off to make this wonderful presentation. Your contributions has been truly appreciated, and I thank you all. Amit, if you don't want to hang around, you don't have to be here. So we have this question and answer for that reason. And it's quite early for you in the morning, I suppose. So take care and stay safe. Okay, for the rest of you, most welcome. For the rest of you, we're going to have a short break of 15 minutes, and then we'll start again. And some of you have been asking, where can we access these videos? I know there's a lot of excitement. You will have to go back and forth with these presentations. But as I mentioned earlier, you have to be a registered participant to the ISSPS. So if you haven't registered, please do, because at the conclusion of the entire series, we will send you a link to the ISS TV channel so that you can access all this in the comfort of your home. So I hope that clarifies this question forever. Thank you very much. So we're going to have a short break of 15 minutes. Dr. Shibata is standing by. I can see that. Hello, Dr. Shibata. And there's some more excitement in store. So please go and have your favorite beverage and return in 15 minutes time. Thank you.